on. So, okay, thank you, Kelsey.
Okay.
Go ahead.
Yeah. I'm Kelsey. I currently work for the psychiatry department at U of M, and I just started getting involved with NAMI.
Great.
That's just a little bit about me.
Thank you. Are you a psychologist or a caseworker, or what do you do with psychiatry?
So I'm a research assistant right now in the neuropsychology psychiatry department, and then I'm currently trying to get to my PhD in neuropsychology.
Okay, great. Thanks. Okay, Pat, you want to go? You're on the bottom there next to Kelsey.
Okay, I'm Pat Streeter. I'm on the board of NAMI Washtenaw, and I'm also an attorney, and I've worked for many years with prisoners who have mental illness. And I'm interested in the intersection between criminal justice and mental health.
Great, thanks. And Annika.
Hello, I'm Annika. I'm a psych and sociology major at U of M, and Hazel and I are in the same psychology class right now where we're doing some project outreach and service learning with the community.
Okay, well, tell us something about yourself, Annika. Where are you from?
I'm from West Michigan, so like 15 minutes away from Lake Michigan.
Oh, cool. Thank you. Hazel.
Hi, yeah, I'm Hazel. Annika already mentioned like the class I came here from, but this is also interesting to me because I'm going into a master's in social work program in the fall. And so this is like hopefully at least adjacent to the kind of stuff I'll end up doing.
Okay, great. Thank you. Oh, congratulations. You're at the end of the rope, so to speak. Okay, Rochelle.
Hi, I'm Rochelle. I'm a retired registered nurse, and I am on the leadership committee of Moms Demand Action for Gun Safe in America, and I'm their liaison to the NAMI group.
Yeah, great. Thank you, Rochelle. And Faith.
Hi, I'm Faith. I'm a licensed social worker for the city of Michigan, and I work for Michigan Primary Care Association, and I once worked for Washtenaw Community Mental Health.
Great, thank you. And I'm Mark Creekmore. I lead the advocacy activity for NAMI. And today we're going to talk about 988. We talked about it last time. Let me give you a little bit of a catch up where how.
Do you want me to introduce myself real quick, Mark?
Oh yes, Summer. I'm sorry. I just.
That's all right.
Okay.
No worries.
Summer.
Summer Berman. I'm the director of Fresh Start Clubhouse, Washtenaw County's psychosocial rehab community for people with serious mental illness. Hazel, also am an MSW. So if you want to chat, feel free to let me know. And we've been doing a lot of work in the last couple of years around this idea of, crisis response that does not involve police. And we've been longtime friends of NAMI. I'm not feeling amazing tonight, so I'm probably going to be a little quieter than normal, which is probably good because I'm usually too loud, but anyways, glad to be here.
Okay, thanks. Sorry to skip over you. Okay, so let me give you all a little background about the thinking that we've had. I've talked with some of our people in NAMI and the Mental Health and Public Safety Group, which is part of the our work with the City of Ann Arbor. So here comes Barb Higman. Barb and I are on the mental health, the committee, Citizens for Mental Health and Public Safety. So I just got started, Barb, so I'll just continue on. So there's a real strong consensus that we should have a panel webinar type of presentation that we can record and play. People can play at their leisure, involving a panel of people, the likes of which might be the sheriff or the person he designates to talk about 911. And this is about the 988 call center proposal that the state is developing. So the sheriff, someone from the community mental health who oversees their crisis call system that they currently have, someone from the city of Ann Arbor, which is considering an unarmed response group and another call center number for taking calls to avoid engagement with the police. And then another person on that group would be a consumer who has mental health conditions, who has had some experience with emergency calling, emergency and getting emergency help. And let's see, I'm trying to think, there's probably one other I'm leaving out. But so those people would maybe talk about 5 minutes. Oh yes, and someone named Krista Hauserman from the Department of Health and Human Services at the state, who is doing the planning for 988. And so each one of those people would do a brief presentation, and then we would take questions. Because there's such a lack of information about the 988 call center plans, and it is really quite complicated. So we need to develop some community awareness. So that there's a lot of agreement that that's going to be a useful thing to do, and is to have this panel webinar. Before, and last time we talked about dividing things up into groups, and I began to realize as I sorted through the information I have to give to these groups that there was a couple of things that we needed to do before we divide them into groups. One is to give everyone who's involved a basic understanding of 988 and how it works nationally and where it came from. And the second thing is to produce a video separate from the webinar, a short video that will explain to others what 988 is. So that people can be prepared for this webinar, and so people can begin to develop their own understanding of it. And so what I'd like to talk to you today is about what are the things, that you think ought to be involved in this basic video describing 988 for the general public. We're talking about 15, 20 minutes presentation, perhaps by several people, certainly not just by one person. So, and I send out a number of files in an email to everyone in the group to sort of kickstart this process of thinking about doing a video, a basic 988 video. So, and there are 988 videos out there, but they aren't really oriented toward Michigan, and they get very quickly into the details, into the weeds, so to speak, and it can be really confusing quickly. So let's just get some comments on that. What do you think of this as a kind of slight shift of plan from what we had talked about last week? I'm looking for a head nod. I see Rochelle nodding her head. Do you have any comments, Rochelle?
No, I just think it's a good idea that we would start the conversation with a certain baseline of knowledge.
Yeah, okay. So anybody else have any thoughts about it or ideas? Okay. Well,
I have a quick question. Is the audience the general public?
I think with this short video, yes. And I think with its webinar, it is also probably less the general public and more the people, the policy decision makers, like the people in 911, the people at community mental health, the people who are starting the unarmed police response program in the city of Ann Arbor. They all have a piece of this pie, but I haven't seen a lot of discussions among them. And this would, I think, would help us. And also the state, bring the state in and have them explain what their plans are.
Yeah, I think
in
that's
more
good.
detail.
Yeah, because those will obviously be kind of two different conversations, right? So like general public,
Mhm.
like, sort of more broad. What is this? Why is it important?
Yeah.
What are situations you might use it? And then those other groups,
Yeah.
gonna be a different.
Yeah, I think it's also important to make sure that everyone has some common knowledge, even the people who are in 911 and the community mental health system have common knowledge about what are some reasonable expectations for this system, because I'll give you a story that happened earlier this week that made me realize that people don't have, can have really surprising expectations. One of the New York Times had an article which showed that the National Suicide Prevention Lifeline dropped, that is, did not actually have contact with 17% of the people who call it. And so the response to that was, oh my God, that's terrible. How could that happen? And how effective is this going to be? And then I began to look at what some of the metrics were about how calls are made and how they're processed and some of the actual nuts and bolts. And I became aware that, first of all, there are many different call centers. There are between 170 and 200 call centers for the National Suicide Prevention Lifeline across the country. Not many of those, I mean, those call centers are different in their level of experience and knowledge. Some of them are relatively new, some of them have been around for 10, 15 years. So, and it became aware to me thinking about, well, you can't really compare at an average groups that have just started with groups that have really been have a program that has been sustained for many years. So there's a lot of important things we need to have to adjust our expectations of these systems. Yeah, Pat.
Several meetings ago, you gave us a preview of a video that I thought was pretty good on the basics. What happened with that? Why are you dissatisfied with that?
Because since I've really come to realize that it doesn't really get into some of the details about how the calls are processed, and that we could use some of that, but that's a good question. We could use some of that, but maybe we should add some information about that.
Well, I'm just thinking that because yours was a good overview,
Yeah.
and maybe add some detail toward the end of how many call centers there are existing in Michigan already. And then some of the more practical things might just wait for the webinar.
Yeah. Okay.
The guest,
Okay.
because if you're looking at a pre-webinar presentation, you want a basic just present the basics.
Right. Okay. I also think that some of them had to do with my preoccupation with how this is a system change, and really most people are not interested in how in systems. They're interested in, does it work or not, and how do I know it works? So I think we need to revise it. Now that I'm thinking back on it.
I think that
Mhm.
again depends on the audience, right? Like, and
Mhm.
what we're trying to get out of it, because I mean, I do think that a big issue is how are all the systems going to work together.
That's true. Yeah, and I just sort of want to revisit that, but it's not like starting from scratch. You're right. Yeah.
And one of the questions to the proposed panelists would be, how does your sphere of activity appear to integrate with this overall state plan?
Right. Yep.
And
Okay.
Sorry.
Yeah, and I think also we need to ask the state some details about their state plan. One of the I'll give you an example in a second, but one of the interesting things that I included in our last email was a report to the New York State Legislature on their rollout of 988, which is really they've been doing for several, I think 5-10 years, and they still have a lot of variation in the responses. So I think the 988 system will provide a much needed level of new services, but it's not going to really there's still going to be variation, geographic variation, for example. So I think some of that is going to be difficult to overcome. So I'll say one of the things I wanted to share with you that I really found useful in the things that I sent out was the report from Michigan about the current suicide lifeline. I'm going to share my screen. I sent it to you, but I want you to look at it in some detail. So this is a report from 2018. Can you see that?
Yeah.
Okay. To the National Suicide Prevention Lifeline, which is the parent of the 988 system. These numbers are a little bit confusing, but let's go through them quickly, and then I'll go to a spreadsheet which explains them a little bit better. There were 71,157 calls from Michigan to the National Suicide Prevention Lifeline. Some of those were transferred immediately to the Veterans Crisis Line. Some of them were Spanish, which went to a Spanish language lifeline, and the remainder, which was 51,000 of the 71,000, were answered partly with call centers in Michigan and partly call centers outside of Michigan. And only 35% of the calls were able to be answered by an in-state call center. So that's revealing. And then you might ask, what is this? And let me show you what that looks like in tabular form. It's a little easier to see. We'll make it one bigger. There's the 19,000 vets. Here's the 71,157 calls. Here's the vets. Here's the Spanish speakers. Here's the in-state. Here's the out-of-state calls. And this is the percentage of that totally. And then if you take out the vets and the Spanish speakers, you get this column of 51,000, which is the total number of calls that the Lifeline system in Michigan was asked to call. And then this shows you that 35% were handled in state and 65% were handled out of state by the other call centers. So that comes out the total number of calls, just for your information. Whoops. Yikes. Is about 195 a day calls for in 2018, and about 5,900 calls a month. So that's going to dramatically increase as the 988 call system is promoted. But it's an interesting baseline, and it shows that aren't capable of handling many of the calls that come to us with our own state system. So that's an interesting comparison. Let me show you where the call centers are. Here are the 6 call centers in Michigan. Houghton, this is up in the Upper Peninsula, Grand Rapids, Kalamazoo, Bloomfield Hills, Mount Pleasant in the center of the state, and Clinton Township in Macomb. So heavily congregated along the lower part of the state, along I-94, if you will, except for maybe Macomb County, which is slightly north. One in the middle of the state and another in the Upper Peninsula. So you can already see the geographic distribution is really skewed. It's, of course, the population is largely in these areas, but so the call centers' capacities depend on their funding and staffing levels. This is what they explain here, and the call volume can strain staffing capacities, and callers may hang up while they wait for the next available counselor. So that's why there's this referral back to the National Center is probably capacity and the capacity to handle the calls. And of course, this is obvious. Some parts of Michigan currently have no coverage for Lifeline calls. So this is one of the big issues. So that really helped me understand. I mean, I knew there were 6 call center lines. So you have this document, you can look at it and look at it at your leisure. But I thought that was kind of a useful summary of 2018, about 4 years ago. And I'm sure the number of calls has increased.
So that's really interesting to me, considering that it sounds like the state is saying we're just going to go with what we've got.
Yeah, and
now, right?
exactly,
Is that
Summer.
what I'm understanding?
Exactly, and I want to point to you why some of that. Here's another graphic that's useful. The calls come into the call center. If the people say they're a vet or need a Spanish speaking, they're diverted. If the call doesn't, if they don't divert, then they're routed to the next local crisis center. And if the local crisis center is unable to call, the call is routed to the national backup. So that's I think it sounds like a department story. Remember when that things used to go on? So, but why is it that that occurs? And there's a question and answer, a sheet that is very informative about the request for when they enter the notice of funding opportunity. That's in the jargon is called a NOFO, notice of funding opportunity. This is the question and answer, which shows the Lifeline minimum requirements, the telephony requirements, and some brief, frequently asked questions where they bid out for getting. And some of the requirements, they're quite extensive. The people, I think is larger. The organization has to be certified by one of these accrediting bodies, first of all. And honestly, that's quite a demand. They have to have insurance that will cover liability. They have to cover a certain geographic area. They have to designate that. They have to have dedicated staff guidelines. They say they have to have 365, 24/7 coverage. But in fact, in the report to the New York State, not all of the call centers do have that level of coverage. So that's an interesting question about whether that's actually been enforced. They have to be trained in the basic call center protocols. They have to engage in, have contractual relationships with the networks of participants. There has to be quality assurance and evaluation, a liaison, and be able to develop a referral system about services within their catchment area. And then follow risk assessment and procedures for imminent risk of suicide. So the point is not to go into any of these in too much detail. The requirements for becoming a call center are quite strenuous. And that's why I think the state is, they're probably going to go with the existing call centers and not expand them at this time. But that's a great question to ask Krista when we have her at this webinar. So it's quite a commitment to make. I mean, just the hardware itself, it has to be, you have to have a computer assisted response system on your telephone systems. I mean, this doesn't even talk about some of the hardware requirements as well as staffing requirements. So it's a serious commitment that the ones that already exist, I'm pretty sure it's going to take time to develop others. So right now we know it's going to be it's going to be not really covering the entire state, except in a kind of very basic telephone call system. It's going to be very hard to have these things as coverage as extensive as it is statewide. So, I mean, yeah, Pat.
I was gonna jump ahead.
Yeah.
And ask about timing. We thought last time we talked about this, that the middle of April was too soon.
Yeah.
What do you, I'd like to kind of narrow it down, because I'm thinking of offering to be involved with some of the invitation process. And it's hard to, once you get in after the middle of May, people start making summer plans, and
Right.
part of an invitation would be to indicate when the program would be.
Yeah, and I think we want to try to use Judy as our moderator, and she's going to be toward the end of May. She's going to be out of pocket. So I think we're talking about the first or second week of May.
Are you thinking weekday or weeknight?
No, don't know. That's really up to consideration. I think we need to really get our principal. I think we need to have the person from the state committed. So that would be my first go-to, I guess, Krista Hauserman. And then I think the other people can fill in, but she's kind of,
Right.
she is a kind of unique one-person show.
Okay.
Yeah, does that make sense to you, Pat?
Yeah, it does. It does. So if it's all right with you, in the next week, I'll write to her.
You're right.
And tell her that we're planning a joint program with MHAM.
Yeah.
And we're thinking of doing something in the first 2 weeks of May.
Right.
And what her general availability would be, should we,
Yeah.
I would think it would be like an hour commitment, or.
Right, and remote. We can handle the remote. And have it recorded, and then what I'd like to do is really, and then I can work on. We can also then work on the other people like the sheriff. 911 is going to be extremely important because that's the call center that really takes most of the calls now that we want to divert through to 988. And so you're not only going to have to communicate and market this to people in the general public, but also get 911 so that they can, procedures that they can develop to divert calls that seem to be crises, mental health crises, away from police and fire and ambulance.
Okay,
Yeah.
thank you.
Yeah.
Mark, I have a couple questions just for clarification.
Mhm.
When a person calls the line, they don't know where the call center is, correct?
That's right.
I don't know if I'm talking to you from Nebraska or Mount Pleasant.
That's right. The 988 is a national number. The 988 person who responds that will be able to be recognized immediately electronically about where the location is, and then again the call rings, and that ring then goes to the call center nearest that location.
Okay, so it is a matter of timing. It's a delay.
And they have protocol. They have protocols for the amount of delay that they will tolerate. It's a matter of seconds, not minutes.
Okay.
Yeah.
And when we talk with Krista, I'm just curious how they're going to carry this out in the UP.
That's right. With only one.
Houghton, that's it.
Yeah, and Houghton is, UP is a big place. I mean,
yeah,
it's as far from Ann Arbor to Houghton as it is to Ann Arbor to Florida.
Yeah,
it's 900 miles, as I recall, because So that is just the rule of life out there.
Yeah.
Yeah. So, okay, so I think I totally agree that we have to do it first or second week in May because students will be gone. People are generating plans. We just enter a whole other lifestyle after in the middle of May. Okay, so does this? I think this at this level of granularity, do you feel some better understanding of how the actual thing will work? I think there is a basic lack of understanding about how the thing, where the calls are going to be diverted to, and I think we need to have create realistic expectations for how the response time and the response capacity of these systems. It is going to vary. So it's definitely going to be something that can be improved, but won't be, it's going to take time just to develop, especially in areas where there's not coverage now. So I'm curious to work from Hauserman is how can this, what's the capacity of the current system to handle this? 35% of the calls is not great by any means. Because that means the calls that are handled out of state, they don't have resource directories about sources of resources in Michigan. They can't really make referrals to people they won't have that information. The resource directory level is going to have to be covered by the state and communities for which there's coverage. So it's not very encouraging as it exists now. And so I'm kind of interested, well, how will this be improved? What can be our expectations for improvement? Yeah.
Sorry, I'm just curious. Do they keep track of what percentage of people end up hanging up the call because it takes too long?
Yeah.
Because I know that
that's
a lot of
point.
people call in and then they never actually talk to somebody.
There is under the metrics. I don't know if I included that. I should stop sharing. But let me just go back to the original email. I don't think I included the metrics, but there are ways there. So that gives us some idea of how they're going to measure this thing. I'm going to stop share. So we have to. That's something that really they do, but there's in research. This is a really perplexing problem. What do you know about the people who don't respond? When the non-responders by definition, you don't know anything about because they drop out. And unless you can call them back, you don't know who they are. So, or why they hung up. So was it because they got frustrated or they, it's just unknown. So I think there's metrics about it, but I'm sure it's going to be really hard to answer that question. I think one of the things to remember is this is a giant improvement from what we have now. So whatever happens, I think it's going to be an improvement from as long as it, in our county in Washington, we already have a crisis call line. I think it's 344-3050. So it could hopefully it won't take the place of that crisis call line. So hopefully those will be calls that we're not receiving through that line now. Yeah, Rochelle.
Mark, is that crisis call line answered by community mental health?
Yeah, entirely. 100%. So, and this is they have made a commitment to, I think, and one of the things we want to ask them is, are you 24/7, 365 days a year? And I think they are. But, there may be some gaps in there.
Well, that makes me wonder if there's really more call centers than we thought. If some CMHs have them.
Yes, there are, but they're not certified and
Ah,
trained in the
okay.
Lifeline system. I'm sure they have equally good training. I hope so, but they're and one of the interesting things is to ask our community mental health is, do they ever plan to become a 988 call center? They may never plan to do that, and that's of course an administrative and choice of the organization and the board of directors. So, so that's, I mean, so what questions do you have that we need to answer? This is information not in our existing presentation to the general public. I think what information is really critical that you think we ought to give people, and what information do you think we ought to add to it? Kelsey, I'm curious to hear what your observations are.
To be honest, I've just kind of been listening and taking everyone's perspective since this is like my first
Okay.
kind of thing. So as of right now, I've been trying to kind of keep an open mind and see how like these Zooms really work and seeing everyone's opinion before I kind of form my own.
Well, one of the things I'll kind of cue on something that you might have some opinions on. We haven't really spent any time saying why this is important. The importance of suicide prevention, that there is some research that shows this kind of system works, that telehealth at this level is really, it's not just a call number, it's a telehealth process where a clinician will actually do some assessment, and so we haven't really spent that much time talking about why the heck to do this in the first place. We talked about it in terms of diverting it away from criminal justice and police as not being appropriate responders. And we talked about how the system is designed to decrease the use of emergency departments and emergency rooms, which also are incapable of, typically most hospitals, really incapable of providing, mental health services. So there's some of that, but not about the. So maybe we need to. That's another area we might need to beef up in our presentation.
I think that makes me think, Mark, about the intersection or lack thereof, maybe at the initial stages of the crisis line and on the ground response teams.
Mm-hmm.
It sounds like right now the initial plan is that it is primarily a telehealth service, but that, looking to the future, that, this might be a great opportunity to interweave some of these, local on the ground, send a van of people, or, with people to help someone. But that, to clarify that, like right now, that's not what this is.
Yeah. And if you really need, they say that they can take care of 80% of the calls through the telephone, but 20% that's left, if you don't have somebody to go out there and help them, then you really do end up taking them to the emergency room or, God forbid, the jail, because there's just nothing else available. And the mobile crisis team and the assessment center which thankfully we have in this county, are the two ways to really avoid. So in some respects, the 988 call center without those elements will increase the demand on the emergency departments. You know,
Mhm.
because if you don't have mobile response teams, and the only place you can really send people are the hospitals, or the police come, they can arrest somebody for their own protection. But the jail is a terrible place to go for mental health services. And it's totally inappropriate. So that's, so you really, I think one of the things that we need to do is advocate among the general community the importance of having mobile crisis teams and assessment centers that can perform those functions. And for the 20% of the people who can't be helped through telehealth, the phone.
Mark, one of the concerns that I've had that you and I have talked about is the lack of providers, be it whatever they might be. Again, in some of the research I've done in the last week, I learned about, that some cities have social workers riding with the police. Now that is the police response. Also that Alabama, I guess, has trained paramedics to do mental health responses because a paramedic can give medications if needed.
Yeah.
So I was going to ask Krista who she sees as being responsible.
Yeah.
Also, ages. Are there limits to the ages? I understand that 14-year-olds can get some mental health help without parental consent. So what happens if a 12-year-old calls the line?
Right. Yeah, I don't know. That's a great question. And I know there are some protocols in emergency departments for a minor that doesn't have capacity. You can have a guardian ad litem or appointed in an emergency, but that's pretty desperate. The workforce adaptions, I think one of the things we need to really promote. There's no reason that a degreed social worker needs to be the only person responding, or a degreed professional clinician. So a lot of people are turning to peers and trained peers. And of course, the supervision is really important, recruitment and supervision and training. But the same happens with in health. You're as likely to talk to a PA, physician's assistant, as you are to a doctor. In some situations, and the emergency. I went to an emergent care for my own health, and there wasn't a doctor in sight. It was all nurses and looked like training students from the nursing schools. They look so young. Maybe I'm getting old. So I think workforce adaptations are going to happen, and we need to really push those because with the increased demand, you're right, Rochelle. This is really going to strain the system. So, okay, any other comments? Hazel, got any ideas? No, sorry to throw you under the bus, but
No worries. I'm kind of in a similar spot to what was said earlier, where I'm just trying to like spend my first time here mostly just listening and kind of taking more time to like collect my thoughts before I like necessarily have thoughts to share.
But let me ask you, what is your, and be honest for God's sake, what is your tolerance for, I sent out like 4 documents, and you're a busy person, we're all busy person, and I can just see a collective eye roll. And what can we do to make this information more accessible? I mean, we could tag, I sort of tried to tag specific pages in documents. what's your thought about that? Is it kind of new? You're a new person, so you're a perfect candidate to have an opinion about that.
I think probably the most basic answer is just like trying to figure out like if you had to give like a 3 to 5 sentence kind of like what's the point of this, and then putting
Mhm.
that at the front just so if people read nothing else, they read that.
Right. So a kind of annotated bibliography and say this is why I'm including this.
Or if this is stuff that's being sent out like through emails, for example, putting
Mhm.
that summary in the email itself rather than in an attachment
Right.
means it's much more likely to get read, I think.
Yeah. Okay. Um, Annika, what's your opinion about this?
I mean, I agree with Hazel. I wish that I could say that I took a lot of time to go in detail and in depth of all the attachments, but I
Yeah.
definitely skimmed, if I'm being honest. And I,
Well,
you know,
that's great.
I did look at them though. But I do think that having just a very brief like thing within the email itself outside of the attachments of like, here's what each thing is like going to talk about so you can look more into it. Just gets people's interest going and like, oh, okay, like I am interested in that. I'll actually look at it. But yeah, no, I'm definitely with Hazel
No.
on that.
Thanks. Faith, do you have any comments? You knew it was coming around to you, didn't you?
Well, I'll be honest, I did take the time to print and read and highlight because that's the kind of person that I am. So
Mhm.
your attachments are helpful for me, and I'm still collecting my thoughts and everything before I chime in on what I think should be added.
Okay.
Or I'll probably talk to you afterwards,
Okay.
somewhere down the road, but I do have a few things that I'm interested in seeing, just not right now.
Okay, good. And your knowledge of how these systems work, both in terms of the health system with mental health and the mental health system, with like CMH and crises is really invaluable. I hope you can share with us because this really does provide a level of service that has not been provided to anybody up to this point.
Yeah, I agree with you wholeheartedly and thank you. But yeah, I will be saying something. I'm still trying to get my thoughts together though.
Mhm.
Yeah.
Okay, cool. Okay, I think we're pretty much at the end of our tether summer, and any more comments that you have?
No, just I definitely did not even see the email before this, just
Okay.
because my inbox is out of control. But as soon as you started screen sharing, I said, "Oh crap, did Mark send me this? This looks really good." And I went to my email and you had, so I was happy to have it in my email, despite the
Okay.
fact I did not look at it beforehand.
Well, yeah, I mean, we all have that overload.
Yeah.
So last question is, what do you all, I really think you should communicate. I hope you can communicate to me the area of interest that is most pressing for you. What in terms of the operations and some of the requirements, the workforce issues. I mean, some of you all who are going into professional education programs, I think it's really, I think when I came into the School of Social Work here, I thought social workers could do just about anything. And now my my attitude toward that has really changed. So I think, it should be really carefully thought about, and I'd love to talk to you about it, but the others as well. I know, Rochelle, you have a lot of experience with, nurses have such a profound effect on health systems and mental health. It's There's sort of in many places there to go the go-to people for systems. So, the director of community mental health herself was a nurse in the system, Trish Cortez. So, well, great. I mean, any other comments or concerns? I think we're going to continue to talk about. There's a meeting this Thursday. If you, I'll send out an agenda before that, and we'll take our observations from here and build on it. And generally, a different group of people comes to that. Yeah, Pat.
Just real quick, in the next week or so, I'll try to reach out to Krista Hauserman.
Okay.
But the information we looked at a few weeks ago was an abridged summary of what was in an email, but it doesn't contain any contact information.
Okay. I'll send you her.
Okay, that'd be great. No rush. But,
No, I'll do it right away or I'll forget it.
okay.
So,
Well, nice
okay.
meeting, Mark.
Okay, thanks, everybody. This is really helpful. I appreciate all your comments and feedback. And Kelsey, thanks for coming. We'll see you
Thank
later.
you for having me for the first meeting. I promise I'll have more input once I get used to the format.
Wait,
Okay,
is Faith new too?
Yeah, I guess you can say I'm maybe a little new still. I started when, Mark? Was it last week?
Yes. Faith is a
Okay.
veteran now. She's been here 2 weeks.
All right, nice to see everybody.
Okay, great.
And Mark, can I also get the contact information for Krista as well?
For whom? Krista?
Krista, yeah.
Yeah, I will. I'll tell you what. I'll go to my, where is it? My contacts. Here it is. Okay. And then I'll just let Hauserman, huh? I guess I don't have. I'll have to share it with you separately. I don't have it in my contact list. Sorry.
I think it was on, I was just looking at it somewhere. Was it? Oh, hold on. It doesn't actually have her contact information. Never mind. It's got her department, but not her.
Right, that's from the email response.
Yeah.
She sent.
Yeah,
Um,
probably have to look her up in the department.
It was somebody who wrote to her. Ed wrote to her?
no, Glenn Nelson.
Glenn Nelson.
Okay.
Okay.
Actually, that's, I can pull it up from Glenn. I don't want to hang people up here.
Okay.
I do have to head out. Thank you for welcoming me and
All
having me
right.
for your first meeting.
All
Nice
right,
meeting
thank
you.
you,
Bye.
Kristen. Okay. Here we go. Okay, I'm going to share my screen. Oh, shit. And here's, I'll blow it up some. Here is Krista Hauserman's information. That's her basic information. And I'll go back up to the top whenever you're ready.
Is that her email address below?
No.
Okay.
Okay, I'm gonna have to answer this just so it doesn't ring. Here's the email address.
Okay.
Hi, Julie, I'm on the line. Just hang on. Okay, text me. Yeah, I guess that's her MDHHS BHDDA MyCal at michigan.gov.
That's probably not her direct.
No, definitely not, but
Trying to find it, but yeah, strangely, usually you can find state employees, but I don't.
Okay.
yeah. I'll send this on to you all.
Okay. Thank you, Mark.
Yeah.
You.
Okay, guys.
Okay. Thanks, everybody. I'm gonna
All
head
right,
out.
night,
All right,
everyone.
goodbye. Thank you.
Bye-bye.
Okay, bye. Good night. All right. Good night, guys.
I was just gonna ask if
Yeah.
the teacher for my class, Sarah Wagner, ever contacted you or not? Because I'm very
She,
comfortable with prodding her.
yes,
Like,
yes.
she's very,
And
I'm sure she might have just forgot if she hasn't. So
no, she did. And she said we traded back a date, a couple of dates.
Okay.
Oh, yes, and actually she received this information as well.
Oh, great.
So I put her on our mailing list. So speaker invitation. I couldn't do when she wanted me to do because, but I said any other time. So go ahead and prod her, and I'm sure
Okay.
she won't mind.
Yeah. Okay,
Okay.
that sounds good.
Okay, sure. All
All right,
right.
thanks.
Hazel, do you
2
have any
weeks.
questions? I know you're new, and I want to give you a chance to, you know,
Yeah, I was just gonna ask to be added to the email list because I
Oh.
didn't get
oh, okay, good. Okay, Hazel Gordon, give me your email.
Hazel GDN at umich.edu.
GDN. Okay,
Mhm.
at
And if
UMich.
you, yep, and we've emailed before, so it would show up in your search bar if
Oh,
you
okay.
if you don't
Okay.
have it later.
Okay, yeah. I try to do it at the time we make contact, but sometimes it doesn't work. So,
No worries at all.
okay, sweet. All right, thanks a lot.
Thank you
And
very much.
have a nice week. And if
Yeah,
you wanted more information, I know we've talked about talking, but haven't really talked. So get back to me.
for sure.
Okay, cool.
Thank you.
Thanks a lot.